This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
All right, welcome everybody to the, I believe, 18th episode here in our Pediatric Hospital Medicine podcast series at UPMC Children's Hospital of Pittsburgh. I am your host, Dr. Tony Tarchichi. For those of you who don't know, I'm a med-peds trained pediatric hospitalist. We've been doing this podcast now. We actually just had our 2-year anniversary, so yay for us. We are in toddlerhood. So I am here this time with my special guest, Dr. Andrew Nowalk. Dr. Nowalk is Associate Professor in the Department of Pediatrics and Clinical Instructor for the Division of Pediatric Infectious Diseases here at Children's Hospital of Pittsburgh. Andrew, thank you for joining me.
Thanks for the invitation, Tony. I appreciate it.
So let's do our disclosures. I'll go first. I have nothing to disclose.
And I will go second. I have nothing to disclose either. I have had past grant support from the National Institutes of Health and Children's Hospital of Pittsburgh for my Lyme disease work, but I am not currently funded by them.
So this episode today is on Lyme disease and other tick-borne illnesses. The way this came about, and Andrew, I'll let you chime in here whenever you like, is one of the things I've noticed, and again, this podcast, I use it as a way for me to learn. So things that come up that I'm not sure of, that's why I bring you all in here. It's very nice. I have noticed I've been seeing more Lyme disease, and I've been seeing it go for longer than I used to. Is that something that's been going on?
So, Tony, I think that's a very salient point, and what you're noticing is not just anecdote, it's data. And so we recently published a paper in Clinical Infectious Diseases, myself along with my partner, Brian Campfield, in the Division of Infectious Disease, as well as Taylor Edens and a couple of other folks on the developing epidemic in southwestern Pennsylvania. So we have noticed, starting in the early 2000s, the Pittsburgh area in southwestern Pennsylvania converting from an area where Lyme disease was very rare, a handful of cases a year, to the situation now where we probably will have about 1,000 coded cases of Lyme disease, that is a billing code that identifies it as Lyme disease, and another 500 to 1,000 cases this year of Lyme disease that were not appropriately billed that are truly Lyme disease at our hospital. So we're talking about a burden of almost a couple of thousand children producing several thousand visits to our hospital each year. And we noted in the study that we published that the severity of cases went up over time as well. And we think this whole phenomenon is actually a neat opportunity for us to understand an epidemic in progress. So we charted in our paper the fact that the Lyme disease cases moved from north of Pittsburgh in rural areas to the suburban and urban areas of Pittsburgh. Cases increased over that period of time. And when we started out with less severe cases, now we're concentrated on more severe cases. And that's an explainable phenomenon when you consider that regular physicians in emergency departments and offices around Pittsburgh, both pediatricians, family medicine, and emergency medicine, as they become more comfortable diagnosing the disease, the early stage manifestations like the simple erythema ligans rash, they take care of themselves. However, the more complicated cases, which become more numerous as the numbers go up, increasingly show up at our hospital. So what you observed in terms of more cases, more complicated cases, fits perfectly with what our data shows as well.
That brings up so many questions. So over what time period have we seen this increase?
So because Children's Hospital is a little bit of a canary in a coal mine, we've been able to track this increase better than actually the CDC or the state. UPMC Children's Hospital of Pittsburgh is the only major pediatric provider west of the Appalachian Mountains in Pennsylvania. So that means that every child with a significant illness is typically going to be referred to us if they have a difficult case or a more serious case. Individual adult hospitals during this epidemic had a small uptick in cases, but because it was distributed among all of those hospitals, many of them didn't recognize that Lyme was becoming more common at all. Because we concentrated cases here at Children's, we recognized it much earlier than anyone else because we were adding all the cases together in one place in children under the age of 18.
So now if you're trying to keep track at home, the name of that paper is Insights from Geographic Spread of the Lyme Disease Epidemic. And again, Dr. Nowalk's one of the authors. Now, do we have a reason why this is increasing? Is it all global warming? Is the deer population exploding? What do you think is the cause of this?
So, again, Tony, a great question. And this one I don't understand as well. So I think we have a great grasp of the fact that the epidemic has been increasing over time. What we don't understand as well is exactly why. And it's complicated. We think, number one, the most important single piece of this is the deer tick, or the black-legged tick, or its proper name, Ixodes scapularis. Very common in this area and on this side of the Appalachians. And previously, we had a lot fewer ticks that were not very infected with Lyme disease. In fact, in some surveys done in the late 90s, they were rarely found to be infected with Lyme. That's changed dramatically. A colleague of mine, Tom Simmons, who's a professor at IUP, Indiana University of Pennsylvania, surveyed ticks around the state in the early 2010s and found that there were infected ticks in every county now. So clearly the ticks have gone up in number, which has been reported, and infection rate. But why? And we don't understand that fully. There is probably an element of deer carrying them, although deer are not critical. It's really a mouse in the cycle of Lyme disease that's the amplifying reservoir host. But deer clearly have a role in transporting infected ticks over long distances. Global warming has to play a role, and that's probably one of the contributors to the fact that tick populations are just much larger. Then the final piece of the puzzle is the way that urban areas are extending into previously rural and wooded areas. And so in Western Pennsylvania, it was a really nice thing, right? Looking out your back door at the deer going through your backyard. And now that's a sign that a lot of these tick-borne diseases are sitting in our backyard. And so we've seen the infections move from those rural areas that had lots of deer and lots of mice and lots of ticks, moving into suburban and even urban areas, parks in Pittsburgh with high rates of infection of their ticks. So it's been a complicated process with a lot of things pouring into it that's ended up with a ton of children and adults getting Lyme disease.
Now, in terms of nationally, are we seeing Lyme spread to areas that previously had not had it in other parts of the country?
So this is Pittsburgh and the southwest of Pennsylvania is really the most dramatic example of new spread of this disease. If you look at national data, there are two main focuses of Lyme disease: the East Coast before the year 2000, and then the upper Midwest, Wisconsin, Minnesota a little bit. Wisconsin and Minnesota have had an increase in their rates, but it's been a modest increase. The East Coast in areas like Massachusetts and New England and New Jersey and New York, especially eastern parts, have seen an increase in cases, but a modest one. And in fact, in some areas in New England, overall incidence is steady or going down. Where the most dramatic increase in this epidemic has been is in Western Pennsylvania. And if you look at the CDC map from 2001, you'll see where they put a blue dot for every case. There's no blue dots on the western side of the Appalachian Mountains. If you look at that same map from 2016, the most updated map, it's solid blue in Western Pennsylvania. So we are the most dramatic example of the expansion of this disease. I do not think it will stop at Pennsylvania, though. I think these ticks are going to keep moving west and probably south, and we'll see a bigger Midwest expansion of Lyme disease.
Are we also seeing, along with Lyme, other tick-borne vectors, ehrlichiosis, babesiosis, increase?
So another great question. One thing we've not seen yet is such a dramatic increase in anaplasmosis, babesiosis, or ehrlichiosis. And fortunately, some of those other tick-borne diseases, which can be very severe, think about Rocky Mountain spotted fever, something we rarely see in Western Pennsylvania because of the tick that typically is critical to the transmission of RMSF. We don't see much in our area, and it's almost never infected with RMSF. In the same period of time that Lyme has exploded in Western Pennsylvania, we've seen no increase in cases of Rocky Mountain spotted fever, and we still have not yet seen an increase in cases of anaplasmosis. I have to say, I think anaplasma will make its way here because we know that the ticks are infected, but we're not seeing the dramatic increase that we saw with Lyme disease. Babesia is an interesting story in that it was formerly really just a New England disease, and now we're starting to see extension of some cases into New Jersey, northern New Jersey, New York, and there are reported cases in northeastern Pennsylvania. Whether those cases are from people who traveled to New England, we don't know yet, but we think that Babesia is making a little bit of a move too. What's unknown about Lyme is why Borrelia burgdorferi, which is the bacteria that causes Lyme disease, made such a dramatic change in its area and was able to infect so many ticks so rapidly in our area. That part we don't understand yet. And when we understand that, we'll probably understand what's eventually going to happen with anaplasma and the others.
So now that we know we're going to see an increase, let's talk about diagnosing Lyme. I think it's reasonable if you wouldn't mind discussing the different phases of Lyme and when antibody testing is helpful. So early, disseminated, late phase, when you should or should not send antibody testing and Western blot testing.
That's a great question, Tony. I think that understanding the stages of Lyme is really going to point you towards how to use testing for Lyme. The testing for Lyme, I'll just state, is confusing. There's an initial screening and then a secondary Western blot. It's actually a little bit like HIV, initial screening ELISA and then a Western blot. Lyme, unfortunately, is way more complicated than HIV in that the second phase Western blot can be very confusing. But if we think about stages of disease, it'll guide you a little bit. And Lyme disease can seem like an illness that has very strange and hard to understand manifestations, but it makes a little bit more sense if you think of it, as you said, early, disseminated, late. Early is what everybody remembers the picture of, the erythema migrans rash. It's a circular rash. Most pictures you'll see in books are target lesions, so they have central clearing, although clinically in practice we see lots of more homogeneous lesions. And this is a rash that is erythema, so it's red, migrans, so it gets bigger. And so if you're trying to figure out a rash on Monday that may be an erythema migrans or not, wait until Wednesday. You'll see that rash expand significantly. And that often helps distinguish it. You also need to be in an area where there's tick exposure to infected ticks. And the erythema migrans in children is often tolerated well without any other symptoms, different than adults. That's early stage disease. Early stage disease testing doesn't work. It's very frustrating. 85-90% of tests are going to be falsely negative. So if you see an erythema migrans, CDC criteria is you've made a Lyme diagnosis. You can report that case to your county health department or your state or the CDC, and you should treat that patient and give them their antibiotic. They will have an excellent recovery. If you miss an erythema migrans, or for example, if the patient has it in their hairline or on their back and it's not seen, they will resolve the erythema migrans over time. And about half of those patients are going to move on to the next phase of disease, the disseminated phase. Disseminated, just like it sounds. Bacteria move from the erythema migrans location all over the body. Lyme disease likes certain tissues. It likes skin, so you can see multiple erythema migrans in the next stage of infection. It likes muscle and heart, so you can see rhythm disturbances, but very prominently in kids, it likes the nervous system, more so than in adults. And so we see very typical manifestations, cranial nerve palsies, especially facial palsies. So a Bell's palsy coming into your emergency department or your office in the summer months in a Lyme endemic area, very likely to be Lyme disease. But it also can cause a meningitis that looks a lot like an aseptic meningitis. And so if you look at these kids, they'll have a lot of headache, maybe a cranial nerve palsy. When you tap them, they're going to have a very, very lymphocytic predominance to their spinal fluid. And that helps to identify this and contrast it with aseptic meningitis a little bit. Finally, what we've appreciated in the last 3 or 4 years of our epidemic here too is we've seen a number of kids with a more septic-like joint, mostly knees. And so those kids come in with a little bit more pain and redness than we would normally expect for Lyme arthritis, as it was described before. But ultimately, swollen knees that come into your emergency department or clinic in the summer or winter season in a Lyme endemic area, you should always think about Lyme disease. So if you're not treated in that stage where testing works really well, then you progress to that late stage, which is almost always either chronic symptoms like fatigue, myalgia, some people report cognitive disturbance, and arthritis. Arthritis is really the hallmark manifestation. We don't see meningitis at that stage. We don't see facial nerve palsies at that stage. Late stage disease is always arthritis and responds reasonably well to antibiotics, though the symptoms will take a long time to resolve.
Now, how often, what's the percentage you'll see erythema migrans in a patient who has Lyme disease? I've heard different numbers from different places. What am I expecting?
So a few things. Number one, I hear our residents often ask, did the patient have a tick bite? And ticks are very good at biting you without you realizing. And if you get an erythema migrans, typically it's from a tick bite you never saw. So I've actually dispensed with tick bite history because it doesn't help me so much. If you have a history of lots of them in the past, maybe. Now, erythema migrans, if you read various sources, some people will say up to 50% of patients don't get an erythema migrans. And I think the problem with that is many of them do, we just miss it. Ticks very naturally home to hairline, and so they will often crawl into a child's hair or hide in places because they don't want to be seen. And so they naturally do that as part of their evolutionary track to try to get their blood meal and fall off of you. So I think that many of the reported missed tick bites, the quote unquote, I never had an erythema migran, is simply the fact that you didn't see it in the majority of those cases. We really think that the tick bites that don't produce an erythema migrans but then do produce disseminated disease are relatively rare.
Since we're talking about ticks, I want to keep going with diagnosis, but I do want to ask, when can I stop worrying about Lyme throughout the year? Is it after a big snowfall, the ticks are either dead or hibernating, or is it now in late fall, or am I still seeing a large number?
Unfortunately, at least based in Western Pennsylvania, where we have 4 seasons, what we found is we see acute and disseminated disease starting in about March and April now, and it probably goes to November. So unfortunately, our Lyme disease season has gotten longer and longer. Part of that is warming, but part of that is just the natural circulation of ticks. You know, if you have a 40-degree day in Pittsburgh, Pennsylvania, you'll have a few ticks actually come out and circulate a bit. And we've not had consistent snow cover throughout the winter for a number of years. So you can be confident when there's a lot of snow, you won't see early disease for a while. But if you have a few warm days here and there, it's possible theoretically you could see some disease. However, because we talked about late manifestations being late, they could happen, early happens about 7 to 14 days after a tick bite. Disseminated happens somewhere starting about 4 to 6 weeks after a tick bite, up to 3 months. And late manifestations are 3 months to sometimes years. So you'll never stop seeing Lyme disease throughout the year. In Western PA, we have not as many cases in December, but we have a number of them in December and January, primarily arthritis or late diagnoses with chronic symptoms. So I would say you never stop thinking about Lyme. You just modify which manifestations you're looking for depending on the time of year.
So now, if I'm understanding you correctly, if I'm a hospitalist in a smaller area or a smaller community hospital, even a big hospital, if I have a patient coming in with a joint that looks like septic arthritis, I think this is Lyme, being that it's probably disseminated to late phase. Antibody testing, IgM, IgG IgM at least will be there. Should be positive. IgG may be positive. Should I primarily test the serum? Should I test synovial fluid for Lyme? And the same question for meningitis.
Boy, that's a great set of questions. So, for arthritis, typically, it's a very reliable test. You'll see IgG reactivity very commonly. We'll often see a lot of IgM reactivity if it's in the disseminated stage of disease. So when I think about a patient with a swollen knee, I think my testing is going to be fairly reliable. I'm not a huge fan of PCR from the joint, although you could say that it complements the serology. We see a lot of orthopedic surgeons, for example, send that if they aspirated a knee. But I think serology does most of the job for you. So you can trust your serology with the knee, and if you have any reactivity that signifies infection, you want to go ahead and treat that knee. We're working on a study right now, for example, from Children's, where we looked at our experience with arthritis over the last 15 years, 1,200 cases of arthritis. You'll see a lot of arthritis if your area becomes Lyme endemic. Meningitis is trickier, and it's a difficult piece here in that the serology is pretty good. Some of the other findings, cranial nerve palsy associated with meningitis, particularly a mostly lymphocytic predominant spinal fluid, is very reliable. You will often find at your system testing available for Lyme PCR from the CSF, as well as testing for antibodies from the CSF. We don't find them clinically useful for 2 different reasons. CSF PCR testing for Lyme just doesn't work well. Sensitivity is very poor, in the area of 10 to 20% in more recent studies. And so, unfortunately, it doesn't detect it well enough, and so I just routinely don't use it. CSF antibodies, you could make a case, because if you detect IgM in the CSF, you've made a diagnosis of Lyme meningitis very well. The thing is, if I have a patient with a pleocytosis or even clinical symptoms whose serology is positive, I don't need CSF antibody most of the time. So although it does have some utility, it's an extra test, which means you need some extra CSF, and I think you can get by with serology from peripheral blood very, very accurately.
Now, I didn't go through this, so would you mind, in the CSF, white blood cell count, glucose protein, if I'm thinking Lyme, what should I be seeing?
That's a great question. So I'm going to give a shout out first to the guy who did the best work in this field, an ID doc named Steve Epps at AI DuPont, who in the early 2000s, 2003 especially, published a really great paper describing Lyme meningitis. And what Epps described was some very significant differences that allowed you to distinguish Lyme meningitis from aseptic meningitis, probably enteroviral. They both happen in the summer, as we just said, and they have a lot of symptoms that can be similar because they are meningitis. However, when he compared cases between Lyme and aseptic disease, what he found was three major differences. Number one, Lyme came in later. So Lyme meningitis would present at an average of 7 days of symptoms compared to aseptic disease around day 1 or 2. You know, we're always taught, and we see it, aseptic disease, worst headache of your life, right? The Lyme headache is bad, but not that bad. And as a result, many of those patients wouldn't present until later in their course. So that's one clue. Second clue is presence of a cranial nerve palsy. And I think that's an easy clue, but it works. So if you have a patient coming in with a typical set of symptoms for aseptic meningitis and they have a facial nerve palsy, almost never happens with aseptic meningitis. It's a hallmark of Lyme meningitis. So the presence of cranial nerve palsies is a second differentiating factor. And then finally, Steve did this beautiful analysis on what the CSF looked like. The white cell counts were almost identical. So, I think about 100 cells for an aseptic meningitis, same thing for Lyme. The differential was dramatically different. So the patients who had aseptic disease would have a differential that had 50% neutrophils on average. So there was a significant number of neutrophils, which has been described before for a lot of aseptic disease. Lyme disease meningitis produced a dramatic lymphocytic predominance. And we showed that in that paper that we published as well, in that 90% of the cells on average are going to be lymphocytic cells. So you can get a good sense of where you're going just by looking at symptoms, cranial nerve palsy presence, and CSF. And if you add those three together, if all three of those are positive, you don't need an enterovirus PCR. You're looking at Lyme meningitis.
For enterovirus aseptic meningitis, what we know is there's rarely co-infection. You rarely have enterovirus meningitis and a bacterial meningitis. Does the same work for Lyme?
Boy, that's a great question. I don't know that I've ever been asked that before, that we've never seen a case of co-infection. Okay. We published a paper recently on Lyme meningitis as well in the last year in the Journal of Pediatric Infectious Disease Society, and we did not have anyone who had co-infections, and we had complete culture data on every single one of those patients. Every single one of those CSFs of the 40 patients in that study was negative, so we've never seen a co-infection.
Now, why don't we finish up with meningitis, and then we'll go into treatment for Lyme in general. But to treat meningitis, this is something that surprised me. I think you and I had a patient one time. We diagnosed with Lyme meningitis. I had called you. My residents had said, we can use oral antibiotics for this. And I said, Lyme meningitis, no way. And we called you, and you said yes. And in fact, there's a paper you were you were the last author on. It was a brief report from the Journal of Pediatric Infectious Disease Society, Oral Management for Pediatric Lyme Meningitis. This looks like it was in 2018.
Yes.
So you can use oral antibiotics. It's as effective.
So yeah, and again, I like to shout out to the people who have influenced me along the way. I am not a cowboy who's giving oral therapy for meningitis with bacteria randomly. I was lucky enough to reflect what we know about European Lyme disease. So there's a lot of Lyme disease in Europe, and in particular, a couple of the species, Borrelia afzelii and Guerinii, cause a lot of nervous system disease. So the Europeans have been working with how you treat central nervous system Borrelia infection for a while. And there are great papers from the early 2000s where they showed in comparisons between IV penicillin and doxycycline and then IV ceftriaxone and doxycycline that they were equivalent in terms of outcomes for facial nerve palsy and meningitis. So looking at this data in the early 2000s and mid-2000s with our epidemic, one of the things that our group asked was, first of all, do we need all IV? Because at that point, guidelines supported using only IV therapy for meningitis. It seemed very clear that we could transition patients to oral therapy. And when we did that, as we published, what we found was the outcomes were no different. So we had in our paper some folks treated with all IV, some folks treated with a dose or two of IV and then all PO, and then a few patients who were treated only with PO medication. All of those patients had identical outcomes. And so what we found was we know PICC lines, when you put them in, are associated with somewhere between a 15 to 30% complication rate. And we know that oral therapy is not. And so we really posited that it would be safe to use oral therapy, either in combination or all oral therapy for Lyme meningitis, using that European experience. We've published this paper, and coincident with the publication of this paper, there's also been a change in the Red Book now. And if you look at the Red Book, it really liberalizes our ability to use oral therapy for Lyme meningitis. I think you're going to see, as the new guidelines come out from the main ID Society, the Infectious Disease Society of America, you will see the option to use all oral therapy becoming very prominent, because we know it works and it's safer than putting in a PICC line.
So if you're keeping track at home, one of the papers Andy was talking about, oral doxycycline versus IV ceftriaxone for European Lyme neuroborreliosis, a multi-center, non-inferiority, double-blind, randomized trial. This was published in the Lancet Neurology Journal in 2008. I haven't done this in a while, but the last names are, if I butcher them, I apologize. Un Jostad, Eric Scoble, Randy Eichland, Rune Midgard, I got that one, Tone Scarpas, Os Berg, and Ice Mygland. Again, if I butchered your name, I do sincerely apologize. I just don't know how to pronounce it correctly, and this is mostly done in Norway. So this is one of the papers you were talking about. That's interesting.
Absolutely.
Since we're talking about treatment, there have been some significant changes in treatment of Lyme disease. Do you want to talk about what has changed in the Red Book and what's coming?
So I'm going to take a step back and pull the lens wider and talk about what's changed overall with the main medication that you and I are talking about here, which is doxycycline. So you and I went to med school, and we learned about tetracyclines, and we learned that tetracyclines, including doxycycline, stained your teeth, and never give it to a child under the age of 8 years old. And, I never questioned that until in the mid-2000s, there began to be some reports, not coming out of infectious disease at first, but from some places where they would use doxycycline as an anti-inflammatory, asthma clinics. There's one in Clinical Pediatrics, I think in 2007, where there was a randomized trial looking at children who were on long courses of doxy and looking at their tooth staining compared to controls. And so this trial began to make the argument that doxycycline didn't seem to be associated with that tooth staining. And then when you look back at the original data on tetracycline tooth staining, you'll find that there's some implication that doxycycline, a newer generation tetracycline that does not bind to calcium very effectively, it's not going to cause tooth staining. We now are sitting on several papers that very clearly show that long courses of doxycycline are not associated with increased dental staining. As that has come out, the FDA still maintains a black box warning on doxycycline under the age of 8. But you're seeing over time the acceptance of doxycycline being used in children under 8 because it's safe and effective. It's always been the first-line treatment for Rocky Mountain spotted fever, and the thought there was, well, it'll kill you. We're not going to worry about tooth staining. But we gave so many kids multiple courses of doxy for Rocky Mountain spotted fever in a paper that came out, I think, in 2015. We've been able to discover that it just doesn't seem to be associated with tooth staining. So now let me focus in on Lyme. Now we know all of this, and we're looking at the European data, which shows that doxycycline is a very effective medication for central nervous system-associated Lyme disease. Now we're seeing some significant changes in the Red Book in terms of an acknowledgement of doxycycline's safety. In the 2018 Red Book, the first-line agent for the treatment of facial nerve palsy in any age is doxycycline. And we here at Children's Hospital fully support that. We've been using doxy alone for the treatment of facial nerve palsy for many years now. Safe, effective, no reports of tooth staining. Now we're also talking about the liberalization of doxy as an agent for the treatment of meningitis. I will not be surprised in the next 10 years or so to see data from our institution and others showing that all oral therapy for meningitis would be fine. I think you'll still see a lot of single doses of ceftriaxone while you're waiting for our culture to remain negative. But in a classic Lyme meningitis, I think you can safely use doxycycline for all of the therapy. Doxy is safe. It's very well tolerated, as long as you're careful about making sure you don't have GI upset. You give it with a little bit of crackers or something. And then finally, it's like an IV medicine in an oral medication. It's superbly well absorbed in the stomach, so rapidly absorbed, and you get peak serum levels in both the bloodstream as well as in spinal fluid that don't look too much different from IV therapy.
All right. Well,
have I convinced you?
Yeah, you have.
All
you
right.
have, you have. And one of the things I've noticed is a lot of the courses for even amoxicillin and doxy have shortened in duration. We've gone from when I first started treating and working, I think it was 4 weeks for septic arthritis or even Lyme. And I think now for a Lyme disease disseminated, we're down to 2 weeks. Am I right?
Yeah. So Tony, you're touching on other changes in the Red Book, which are interesting, and I think there are bigger ones to come. I always make fun to the residents of the treatment durations for Lyme in the older Red Books and the ID Society guideline because they're all over the place. Here's what we know. We know 14 days of therapy for an erythema migrans is safe and effective. We also know that 28 days of therapy for an arthritis is safe and effective, and if you go shorter for either of them, you tend to see relapses. What we don't know is the appropriate duration of therapy for the other manifestations. What we're starting to see is some relaxation of those longer courses, or one of the durations that was suggested in the ID guidelines was 10 to 28 days. That doesn't help me at all. Right. But now what we're seeing is more unifying treatment courses. So in the Red Book, you'll see now you have the option of 14 days for an erythema migrans or even 10 days of doxycycline. Doxy has a long half-life, so that's very reasonable, and there's good evidence to support it. As you mentioned, for disseminated disease and facial nerve palsy, which had been all over the place before, now the recommendation is going to go to 14 days. I will admit my prior practice was to give 14 days for an EM and to give 28 days for everything else, primarily because I was trying to make sure that we gave maximum treatment. So if they returned to my clinic, that I could say you've been maximally treated. I was probably over-treating with that. And now that the guidelines are becoming more coherent, I'm probably going to use a lot more 14-day courses for disseminated therapy and facial nerve palsy. The guideline does suggest 14 days at a minimum for meningitis. I will tell you that I agree with that. I do still tend to use a little bit longer course for meningitis. But also another change in the guideline is for carditis, which had previously been an IV only. We all now acknowledge that carditis, once you see a change in the block, if it's a high degree block, will all change to oral therapy quite quickly. And the guideline reflects that as well. So when you're thinking about when am I going to use IV therapy for Lyme, I think the only absolute indication now is probably high-grade heart block in carditis. Second or third degree heart block until you get that kid stabilized, because you really want bactericidal activity, you want it fast. In all of the other forms of Lyme, I think there's a growing body of evidence that we can use shorter courses and doxycycline as the first line, and we're going to get the job done.
So in the adult literature, one of the things we have is if someone gets a tick bite and it's noticed, and they're pretty sure it's an Ixodia scapularis or a deer tick, you can give 2 doses of 100 milligram doxycycline prophylactically if you take the tick off right away to help decrease the rate of Lyme converting to Lyme. Do we know if that works in the pediatrics now that we can use doxy more? And has it ever been tested for amoxicillin?
So that's a great question. The prophylaxis where you're living in an area where Lyme's endemic, and it's a deer tick and it's been on for at least 36 hours. It's a tough question. There's a lot of specifics there. But in a Lyme endemic area, especially in rural areas, you'll run into that scenario from time to time. What we know about the efficacy comes from 2 papers. Gene Shapiro, another shout out here. Gene Shapiro, who actually did his training, part of his training at Children's Hospital of Pittsburgh. So we'll give him a special shout out on this. Gene published a paper on amoxicillin and a paper on doxycycline. The amoxicillin did not show a treatment effect, although he said in the paper itself the sample size was small, and maybe with a larger sample size he would have seen it. You had to give several doses of amox, though, so Gene was not too excited about that. He published in New England Journal the classic paper about prophylaxis, showing that if you had a bite by an infected tick, and you gave a single dose, actually, of 200 milligrams of doxycycline, that would protect against Lyme infection to the tune of roughly about 80-85%. And so in the IDSA guidelines, we see that prophylaxis for tick bites is recommended with all of those cautions that I mentioned, and we think should be fairly effective. We've recommended that in our area for the last 5 years. I will tell you 2 observations about that. I think it's quite effective because single-dose doxy is tolerated by most. But if you're in an area that's as epidemic or endemic for Lyme as ours is, and you have a patient getting a ton of tick bites, what that means is over and over and over and over again, they're getting a single dose of doxycycline. If you can see where the tick bit you, I mostly advise parents now you don't necessarily need prophylaxis. Keep an eye on the site. You know exactly what you're looking for. And if in 21 days there's been no red rash that originates there and spreads out, then you're probably Lyme disease free. One of the key things figured out in both Gene's study as well as the older vaccine studies was that Lyme-infected ticks, when they bite, only rarely pass Lyme disease. So it's only about 1 to 2% of infected tick bites that will actually pass Lyme disease, transmit Lyme disease to the host. And so when you think about that, it's a very challenging thing. You have a very low rate of transmission, and you have a site of the tick you can look at. Most of the time now I've shifted my advice to say just observe the bite, unless you're only infrequently going to be getting tick bites.
So that kind of segues into something we do want to touch on, is the dreaded chronic Lyme concerns. Now, there's a paper we have that I'm fumbling around for right now if you're listening at home, because I thought I had it very easily accessible, and I was wrong. Whether or not, A Critical Appraisal of Chronic Lyme Disease. Authors Henry Fetter, Barbara Johnson, Susan O'Connell, Eugene Shapiro, Alan Steele, Gary Wormser, and the ad hoc International Lyme Disease Group.
I will point out, Tony, that I found that paper for you, so I want credit for that on this podcast.
You did. On my desk, he found it. We're back in my office, ladies and gentlemen, if you're at home. This was published in October 2007. I like this. It kind of said that there wasn't chronic Lyme disease. Now, we always have patients asking about it. They're always Googling it, and it's everywhere. What do you tell families?
So Lyme disease, interestingly, having stumbled into it as a researcher, is challenging because besides the anti-vaccine movement, this is really number 2 with a bullet next to the anti-vaccine movement in terms of internet mythology, but also information. Again, it's never mixed, it's never pure mythology, it's always mixed together. And so this is a very, very straightforward observation. You have a lot of patients who get infected with Lyme disease, and if they've been infected for a long period of time, they've often been sick for months, because this can be a very, very long infection in the late stage. So those patients have been infected for months, and I give them a course of antibiotics for their Lyme disease. I kill those bacteria. There's very few left, and I kill them all, and I'm confident of that. We have lots of data from lots of basic and clinical science studies to say that I kill the infection. The infection is resolved. The patient comes back to your clinic 28 days later and says, "Doc, I know you keep telling me you cured the infection. I don't feel any different. I still feel sick." Or they come back with an arthritis that after a month of therapy is still a bit swollen. So one of the most important things we've done a bad job of as physicians is distinguishing between what is chronic symptoms after an infection's been treated and chronic infection. So chronic Lyme disease is a misnomer. There's no such thing as antibiotic-treated chronic Lyme disease. When we treat it, we kill the bugs and the infection is gone. But this is an infection that leaves a lot of damage. In some things we understand, and in other things we don't understand well. What we see in chronic Lyme are a set of complaints that are often stereotyped. You can have chronic joint complaints, and in fact the knees take a long time to go down sometimes if they've been infected for a bit. But you see patients come back, and for you and I, it's not going to be the 5-year-old, but a 15-year-old will often still have fatigue, myalgia, arthralgia, and many of them complain of cognitive changes that they know and they notice, and in school their performance degrades. So in that situation, you got 2 choices. You can say, well, they're making all that up. Or you can say, you had a serious infection for a long period of time that did damage, some of which we understand, and some of which we have research going on to just try to grasp why it happens. Why are people chronically fatigued? Why do people have chronic myalgias, fibromyalgia, and other things like that? We don't understand them well. But these patients, when they come to me, are clearly ill, and they don't feel well. And so what I try to explain to them is, we know that this happens with lots of other diseases. The closest cousin of Lyme disease is syphilis. And if you get treated for syphilis after 3 or 4 years, and you have damage to a heart valve, no one in the world is going to say that you're faking that. So that's an infection that if we treat, and we can still treat often with single doses of antibiotic and kill all the bugs, can leave permanent damage that's lifelong to your heart, to your brain, to your muscles. So for some reason with Lyme, we've done a poor job of explaining that the damage that you get from the infection can leave you with symptoms that persist for a long time. And then the key point here, and I can't emphasize this enough, that damage is not remediable by antibiotic. When people get months of IV ceftriaxone to treat this, and I'm putting air quotes up around treats, they're getting placebo effect. There's no biologic evidence, as described nicely in that paper, that we're killing any extra bacteria. So when I see those patients in my clinic, number one, I sympathize. And number two, I engage any resources I can in the community to help me. Sometimes I'll use physical therapy. Sometimes I'll use NSAIDs to help with the aches. Sometimes I embrace alternative practitioners because they have a better chance of making that patient feel better than I do. And if they're embracing that alternative practitioner embraces harmless therapies, then great. I've had patients get better with acupuncture. I've had patients get better with therapeutic massage and things I don't know that have a great evidence base, but if the patient's getting better, then I'm happy about that. This is a problem because the patient groups recognize that many of them are kicked out of offices and are told that they're kind of making this up. I don't think teenagers or younger children make these symptoms up, but I also don't think IV ceftriaxone is ever the answer.
Well, I think I agree. What I've sometimes told patients is if they live in an area that's endemic to Lyme and they're outside a lot and they got bit by one tick, they will probably be outside some more and get bit by more ticks. So they may be getting reinfected, and that may be why the symptoms reoccur if they go away. Does that sound reasonable?
That sounds reasonable, but one thing I will point out about Lyme disease is, we used to have a vaccine in the late 90s that was effective. It came off market because there wasn't much demand and there was a lot of concerns about safety, and some of which I think are unfounded. But we know that someone with chronic Lyme infection makes a huge immune response. It's the only Western blot you and I like to read. The Western blot where every single one of those 10 bands on the IgG blot lights up as reactive. So you and I would both agree that's chronic Lyme infection. Those patients, if treated, often feel poorly. But the key is they can't be reinfected for years. Their immune response, they make an immune response to the target of the vaccine and the target of a lot of other proteins on the bacteria. So they have long-lasting immunity, not lifelong, but immunity that lasts for years. And so those patients, I really caution them, try not to let anybody test you for Lyme again for years. Because if you're going to retest that patient, there's very poor specificity for the serology after that first episode. And I emphasize to them that if someone tells you you have Lyme disease 6 months after you have a hugely positive Western blot, I think that's impossible. So I modify that a little bit. And I'll say, after a few years, you'll be more susceptible. We know the erythema migrans patients are susceptible almost immediately. But if you have a very, very strong serologic response, you probably gain some protection against reinfection for a longer period of time.
Now, if we continue to see an increase in this Lyme, can you foresee that vaccine making a comeback?
I would love to see that vaccine make a comeback. A version of that vaccine is still used in pets, in animals, and it's very effective for dogs, etc. It's not the longest lasting immunity, so it does require boosting, but in the studies done in the late 90s, it was a very effective vaccine. I would love to see it come back. I know personally the company is not so interested right now, but if this epidemic wave rolls across the Midwest, I think we're going to have more and more reasons in our patients over the next few years to bring the vaccine back.
Well, Andy, those are all the questions I had. Is there anything you want to say before I think we sign off?
Well, I appreciate the invitation to talk about this. It can be a confusing disease. The testing in particular, we need better testing. And there's, I think, some innovations ahead in the next 5-10 years that'll make it easier for you in an office setting to diagnose Lyme. But I would just encourage people, remember that this disease is stage-based. The testing works well for the later stages, and that persistent symptoms happen a lot, and that they are not due to bacteria typically that are still there, and they're not remediable by antibiotics.
All right. Well, ladies and gentlemen, thank you very much for joining us for this episode. I appreciate you all being here. I want to say thank you again to my guest, Dr. Andrew Nowalk. Thank you very much. And we're going to do our usual acknowledgments. Thank you to UPMC Children's Hospital of Pittsburgh, my division, the Paul C. Gaffney Division of Pediatric Hospital Medicine. Of course, to Dr. Megan Keene Tarchichi, who helps me with everything. I want to give a shout out to the UPMC Children's Hospital of Pittsburgh new podcast, That's Pediatrics. Take a listen, especially to their episode on AFM with Dr. Williams and Dr. Carolyn Boyne and Brian Martin. We'll see you next time. Our next episode is going to be on vascular anomalies, and we're going to gear it towards inpatient hospital medicine, things you may see and things you should know. So until next time, thank you very much, everyone. You have a great weekend. If you have any suggestions or comments for a podcast, compliments, or anything, please feel free to email me at tony.tarchichi, TARCHICHI @chp.edu. We'll see you next time. Thank you.